we do genomics on these patients, find out who the people are who hemorrhage. Maybe they have distinguishing genes, and we can do that preliminarily. And so this person can go to 50 easily, this person better stay at 80, you know. This is evolving medical science.
May I ask a question? So currently, like if you were speaking to a patient and you wanted to bring their LDL lower, would you then take them off, say, 1 aspirin a day? Would you try to take away some of that risk by taking them off?
Well, I don't know whether that contributes to the risk. I don't know the mechanism, but I do know that if the patient has LPA, that aspirin not only lowers the level appreciably, but it reduces the risk of thrombus. And so our LPA patients, we have on it, unless some of them are on Eliquis or something, you can't give aspirin with the Eliquis. So you have to, you know, really analyze what you're doing with the clotting. But that's a very current daily consideration for us.
So you would say that you would prescribe aspirin based on some further testing, and this is very important to our work in San Diego, because where we had the ALL protocol used quite extensively while we saw a lowering of AMIs and ischemic stroke, we saw a slight uptick in hemorrhagic.
Well, if we can get the proper genomic markers, we can, you know, conclude that Alan Thomas here ought to have concentration on his LDL and LPA and so on, and someone else is in danger of stroke and will do something else. Now,
But
this is
I should just say that the
personalized.
conclusion there, though, was that we lowered heart attacks so much and
Yes,
mortality
dramatic.
so much that it
It
counterbalanced
may
the
be a
concern
trade-off.
about the small.
You're
number of
accepting a small
hemorrhagic.
risk of, you know, but I think we need to refine that analysis. And it may be, my point is that in terms of genomics or maybe some of the other measurements we make, sophisticated lipids and, you know, cytokines and so on, that we can pick out with whom we should go in each direction. And I think that's the ultimate. But we're in a new place in medicine, aren't we? So, okay. I really wanted to just mention that lipoproteins do other things, so we have to think about this, because we accidentally discovered that triglyceride-rich lipoproteins complex endotoxins from gram-negative bacteria. And we actually went on to show that that's protective. So if you don't want to wipe out triglyceride-rich lipoproteins completely, and what's been published since on the basis of our discovery is newborn children, babies, in the ICU who have sepsis survive better if given intralipid. Intralipid complexes the endotoxins. And so you don't know where these things are going when you find them, but anyway, we're pursuing that. But we think that actually administering or stimulating lipoproteins in some circumstances will be protective against septic shock. And we showed that in animals. So, all right. There's another issue. Staphylococcus aureus is smart enough, millions of years of experience, to not want to start an infection until there are enough organisms, because we have a lot of mechanisms that can knock off a few here and there. So they have a protein called the quorum sensing protein, and it goes around counting the staph. Are we enough to attack or not? When you reach that point, it turns on the infection genes in the organism. Well, it's now been known, we didn't discover this, I'm just delighted to hear about it, that the B apolipoproteins, B100 and B48, have a sequence in them that complexes and, what do I want to say, immures the quorum sensing protein of staph. Says, no, you're not going to start an infection. How do you like that? So, so we need to think about these things when we start lowering LDL levels and so on. It's present in both B48 and B100 in the N-terminal part of the protein. But you know, that's a new discovery, and it's kind of fascinating. So anyway, Cantos, we've mentioned, maybe everybody here is thoroughly aware of this, but in effect, using an antibody that immobilizes the interleukin-1 beta cytokine improves the outcome quite measurably in repeated coronary artery disease. So this establishes for me the importance of cytokines. And in our studies now, we have a panel of 65 cytokines. So people measuring 1-beta and interleukin-6 and a couple of things, we measure 65. And we haven't published this yet. We have astonishing correlation with risk in people where you wouldn't necessarily read that from LDL and all the other things. So this is going to be an element, and we'd love to get this into some studies that you may be thinking about or collaborating on. We think that these cytokines are going to be definitive. We have a person collaborating with us who does things I don't think I could ever do. Machine learning, studying the interaction to the 65th power of these different cytokines. This is the future. She does 2D plots, and none of this has been published so far, but I'll just share it with you. When she gets done, there's a pink zone over here and there's a blue zone over here. The people in the pink zone get coronary disease, the blue zone don't. And it's just astounding. And she can wrap into this pre-beta-1 HDL or other things that we can measure. So I think we're going to get to a point of, a plurality of risk factors interacting and giving us, through the interaction, effects that you can get at with machine learning that you'd never in the world know about otherwise. And you see these 2D plots, your jaw drops open, So I think this is where we're going. And this person is going to tremendously add to our studies, I think. So, see what I want to say about this. I've already told you quite a little bit about it. Well, yeah, LPA compounds virtually all the risk factors we know about. And just to look at, the insurance companies, when we order LPAs, many of them are telling us it's experimental and they won't pay for the measurement. How many of these are on the right side of the line and how many are on the left? Okay, I think it's established that LPA is a risk factor for coronary artery disease. I'm talking right now to a colleague of mine who is one of the leading plaintiffs' attorneys in California. We may make this a legal issue.
I can just pause on that for a moment for everyone who's practicing as well with patients. I mean, I think that the Lp(a), CRP, these stories have come and gone, and now they're kind of coming back. And is it considered standard of care in your patients? I mean,
what is in our clinic?
But you see a highly specialized group of
Yeah, but those people we need, but I think everybody needs, you have no idea what your LPA is.
Right.
And if you come from India, you're more likely, or if you're Norwegian or whatever, but that's the best you can guess. And I know Norwegians with a 5 instead of a 100.
But because of what you just showed, I'm curious, and sorry to interrupt your talk, but I'm just curious
Go right
if,
ahead.
like, practically, in the general kind of cardiology clinics, or, I mean, we deal with patients who are having events, so maybe we're not checking it because we already have identified their risk factors in treatment, but I'm just curious if like protein a comes in your practice.
Well, we are asking all the people referring patients to our clinic to measure an LPA with a reliable method. I think it's passé otherwise. I mean, we've left that place in time, I think.
We're also getting referrals from neurologists now with young people with cardiovascular, with
Cryptogenic stroke.
Yeah.
with strokes with very high LPA, so.
5 years old, 12 years old,
Yes.
with,
Very young.
and they have a pattern of high LPAs. I think this is highly significant.
That last slide, the back one.
Back one, I guess I can.
So what,
We'll go to Bob and then.
my eyes aren't that good. What is that? What are all
Oh,
these things?
this is all the association of LPA with vascular disease. If you're in the middle here, it's neutral. If you're to the right, it's associated, and if you're to the left, it's not.
So what are all
So I
those
think
things in
those
tiny
are
print?
names
Pardon me?
of studies.
They're all studies.
They're names of studies.
Oh, studies.
Yeah, they're all
Like
studies.
Eric.
I see, okay.
Yeah.
Just, I can share this with you.
Cohort,
That's
bunch
fine.
of cohort
Efforts.
studies.
So they're all, all but one of these studies essentially have shown an association with risk. So, we can stop arguing about it, I think.
How expensive is this test?
Not very.
Like
$25.
$25, okay, so, I'm sorry to have interjected, no, go ahead.
Just a quick question, so, but if the LDL level is below normal, do you still need to get?
Yes,
LDL?
they're independent risk factors, because this does some things that LDL doesn't do. So, and let it out of the bag that we're talking about a class action suit, if you're involved with.
You had a good question. Someone said,
I mean,
Is that Dr. Yu from
Yeah.
Palo Alto Medical Foundation?
Yeah, sorry, a little late. So we're very interested in looking how we further segment the population. Because again, I understand when you already have events enter a different category. We struggle over here to know in our general population who should be screened, who are the prime candidates that can benefit from that, and where are there existing, where would it really add additional value that makes significant difference in treatment options that we would not have otherwise with standard things that we do. I mean, right now, we're all using a CVD calculator to stratify risk with
Yeah.
other limitations. That'd be very helpful for us
Well,
to know.
what we're talking about here is going beyond the conventional.
Yeah.
And some of the things we measure at a time 20 or 30 pre-beta-1 HDLs where you run 4 runs a day. I mean, this is something that can be done. And the cytokine panels, maybe once in somebody's lifetime, you can measure a cytokine panel, pre-beta, LPA, all this sort of thing. And, goodness, what did I do? I hit something? Oh, well, I really need your help. Anyway, I think that's what we're talking about is, how much does it cost once in a lifetime to take somebody and find out whether they have, a very high level of interleukin-1 and beta or something. And that may tell you about future nephrosis or other things.
So I think that would be ideal to get there. However, what I was trying to get at is if we're going to start with a smaller segment, who would be the prime candidates? Are those young patients that have family history of cryptogenic strokes, for instance? So
I
that's
think
kind of where we're.
Family
that's
history
helpful.
of vascular disease is a good place to start, yeah. I'm sure you'll find a higher percentage of positives if you look at them.
Yeah.
So,
So having epidemiologic studies to kind of help us understand that would be very, very
yeah.
helpful.
No, this is evolution, but.
John, is there a specific number that's high for Lp(a)?
Well,
It's approaching
the
4 or whatever the number
the
is.
standard first thing, there are two units of measure, milligrams or nanomoles. We're trying to get everybody to use nanomoles per liter. 70 nanomoles per liter is the upper limit of normal. We have a lot of people in the 800 level. We have one college co-ed who has 2,400. And I don't know,
So when you find that 2,400, I think what Ed is saying is, what do you do about it?
well, we have her on aspirin, we have her on niacin, and there is coming on an antisense trial. Antisense oligonucleotide for LPA, and we hope to be a site. And so this will help us a great deal to identify those people. Because the antisense is powerful. The preliminary publication in Lancet was about 90% reduction with no side effects.
I just want to tag on to what Dr. Yu said. Is screening everyone? Is it just family history? Do you have any specific criteria? Because, when it's coming from a health plan, we want to know, what do you mean by screening? Is it screening across the board?
Well, we have to find our way through this. We're just finding these risk factors. So this is a kind of a collective thing. But I would say that it's not that expensive. You get scans on people, you get all kinds of studies that are far more expensive. And I think LPA costs $25. Well, that's a pittance compared to what you learn. And so I think we need to set, as we go along, some kind of, maybe it'll be based on family history. If you have early inflammatory disease or active vascular disease, you go sooner, go broader. But I think that, some of these things are obviously on board already. I think everybody in the world ought to have an LPA. So,
So somebody previously suggested that cord blood be tested for certain things like Lp(a). What would be the right time to do a baseline? Say, should everybody have, just to make it easy for doctors to know or health systems to know what to do, should there be a baseline of everyone at age X? So then how how to do the primordial sort of prevention?
Well, I don't know that I could answer that, except to say that I think there are a lot of things in life that may come along that would modify this. And one of the things I want to project for everybody is the intestinal biome. You know, the average person has 1,500 organisms, something like that, and you share 600 or 800 of them with your spouse and your friends and so on. And these are going to have big impact because I mean, I already know I've sort of stumbled into a situation where I think the intestinal biome has a neurological effect. We're going to be probably publishing that. So, you know, that's something that comes along after you're born. And so I would say, you know, there may be other influences, but certainly, I mean, genomics from the beginning, if you did, you know, whole exome studies are getting pretty inexpensive now. And we found, just in our lab with our collaborators, 27 polymorphisms associated with coronary disease and 7 with stroke that nobody knew about. So how much more of that is going to be? But I think that it should be just part of biology.
Thank you so much for sharing. So, yeah, it is fascinating that it's not just part of, like when we all go for our annual physical, right? They run a very baseline of blood work, which we've been doing that for many, 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 many years.
Yeah.
And here, as what best practice does and uses today's technology, why wouldn't that just get added in? Because we already know what we're doing now isn't working.
Well, in 1900, they measured the hemoglobin, and that
Well,
was
that was
it.
gonna be my next question, is how do you
So,
treat it?
you know, it's evolving, and I think we should be adding new elements as we prove their value.
I really think a big barrier there is the lack of effective treatments for an increased Lp(a) level. So you diagnose it, and then you're sitting with the patient who then Googles and comes back to you psychologically totally distraught, because there's really no treatment. And high-dose niacin, I mean, if any, that's the last thing I'd give a patient. I mean, I think the risk of hemorrhagic stroke with the doses needed to lower Lp(a) are probably higher than the risk.
I think you got a point, but it's very individual.
Yeah.
I have a guy who at 42 started having vascular disease everywhere, and it turns out that his LPA was 813. I put him on a reasonable dose of niacin because we didn't have anything else, and it went to 13. There are some individuals where you get a profound effect from niacin, and I think in his case, I've been following him now for 20 years and he's never had another event. He also has, and people need to know, a high homocysteine. Homocysteine interacts with LPA. His homocysteine, instead of being 15 or so, was 300. I put him on betaine, and I brought it down to about 30. And he comes from Holland, from Leiden, and he, by golly, had factor V Leiden. And so we got him on medicine for that. And in 20 years, he hasn't had any more coronary disease. So I think it's pretty individual.
Well, I think
He's
that's the
talking
key,
about
is the
precision
individuality.
medicine, and then at the other end of the table, Ed, you is in charge of quality improvement.
Population.
Get individualized.
How many patients do you take care of then?
Oh, well, we took care of a panel of million patients, yeah.
So he's gotta have some protocols
Yeah,
to use.
but you can measure homocysteine for about $30, you know? If you got a high, don't measure homocysteine,
That way
till the LPA comes back, and you get it.
Adds up,
So do you
right,
think
a
a
million
reasonable starting
times
place
30.
for a baseline would be maybe all of their patients with strong early family history of a coronary
I would
or
say all of their
stroke?
patients walking through the door should get an LPA. And if you have an LPA of 100 or something, then you get the homocysteine to go with it. Because you may be surprised, you get 1,500 homocysteine, and you've got a catastrophic combination. You know, we only order the homocysteine in 1% of patients or something, or 15% or something. Anyway, this is what LPA looks like. And you see this kringle structure here can go from 4 to 40. And so people with different number of kringles can have some pretty different biology. And we need to think like that. I don't want to go too slow here.
So this
Okay.
is, I'm on sort of a rant today about the need for protocols to make it easy for doctors to know what to do. So the super cardiologists and endocrinologists believe that it should be obvious to everyone, okay, well, if you have this super high Lp(a) and super high homocysteine, what do you do about it? So we need to give them easy approaches to deal with a large number of patients
That's a very good question. So what can we do about high LPA? Aspirin. Baby aspirin lowers the level appreciably, but interferes with the abnormal effects on clotting. Our group, collaborating with some people in Poland, of all places, was able to show that the clots that are formed in patients with LPA are structurally abnormal and not responsible to fibrinolysis in a normal way. And so the aspirin prevents that. So patients with high LPA should get ASA unless they're on Eliquis or something and you gotta rethink everything. Don't want to get in trouble with that. But aspirin is compatible, I understand, with Plavix. Some of you may comment on that. But so that's number one. Number two, there's demonstrated benefit for people with high LPA if you get the LDL down, get it down to 60. And so you can do those two things, but we are just months away from this trial of an antisense oligonucleotide that's a slam dunk, it looks like, in the preliminary work. Hopefully we're going to have it at UC, but
So I think that since Hattie wants protocols, there's data in women for lowering LPA brings down your cardiovascular risk to almost normal population levels. So that data is out there, it's been validated, so there's no reason to fear, I would say, in that sense.
I guess I'll play the devil's advocate from a population health angle, right? We just can't screen 100% of people, and for medications that they may already be on, like Aspirin. So you're talking about the people where there's some risk and they're not yet on treatment, or they're not clear that they need to be on treatment.
you have no way of looking at a patient and saying, I think you have a high LPA. No way.
Because they're on an aspirin and stuff.
No, but I
already,
mean,
so I can't, I just.
I think, I'm going to make the statement, I think everybody coming through the door ought to have an LPA. It's only $25 for heaven's sakes. And, you know, as you go through life, you're going to pay a price with stroke, with aortic valve disease, with all these things. We know
You know what happens too, is that then you have new guidelines come out that say, okay, people, or like that New England Journal article that said, take people off your aspirin for primary prevention.
not
because
if they have a high
it doesn't work.
LPA.
Not if you have a high
So I
LPA.
So it's the people who aren't on treatment or are getting off treatment.
How many lipoprotein
Oh, yeah.
patients would you miss if you only screened those with a very early family history?
A whole lot, because it interacts with a whole lot of other risk factors and so on. And, you know, there's so many things at play that a person with a high LPA who has psoriasis is going to get into trouble sooner than, you know. So I think this is so inexpensive. What's wrong with just measuring it? You know?
Well, I think, well, this is for you, Hattie. I think going along, I think we're on the right track. I really appreciate your passion and all that, but I'm a primary care physician, and you're coming to me with a lipid, everybody needs LPA. Then the neurologists come to me that everybody should have this test.
A MOCA, cognitive screening.
And at that point, it becomes
Just as released.
unattainable for us to know. So it goes back to, and also from us, from a preventive health standpoint, great that we have a test that correlates with the risk. I think also what David mentioned too, is also important that there is effective intervention that can change outcomes on that.
But we already have something that works pretty well, and within 2 years, we're going to be able to knock this
I think
thing.
that aspirin thing is just, you've taught me something this evening, which is the aspirin. And that's really important, because we have this whole movement, you know, away from aspirin. Well,
Yeah.
you know, perhaps, I mean, the 10% of people that might be out there, or 5%, you know, that needs to somehow, you know, come through.
And the
Guideline committees.
debate in the New England Journal did not mention LPA.
No, I know.
We
So-
sent our letter in to say,
Okay.
hey, you know, what you say is okay
Yeah.
for everybody else, but it doesn't hold for people with
Do
high
you use a full dose of aspirin, or?
No, you just need 81 milligrams all
81.
day.
So where does the AHA, like the large organization, stand on this?
They are
Pushing them.
in darkness,
They're-
okay?
Yes, they are.
We have no-
You need to do this.
Yeah, but it's a,
Pardon me?
How often?
Well, the thing is that
What
the
impacts?
the level of LPA is largely genetically set. If you have nephrosis or some other things, it will pop up. But otherwise, it's surprisingly level from age 10 to age 100. And so you know, you don't need to measure it all the time.
That's great.
Unless you're intervening and want to see how you're doing with it.
Okay.
But your one measurement, that's all, $25.
So it should be part of primary prevention screening, in
I-
your opinion?
That's my belief, and I think,
But aspirin only for those people with elevated levels?
at least unless
In
you got
primary
another,
prevention.
unless you have another indication for it, you know, thrombosis for some
Because
other
in primary
reason.
prevention, we're not really doing aspirin anymore.
Not one, yeah.
Which is
that's right.
probably a mistake.
And
Well,
the guidelines.
Well, the meta-analysis that the task force did showed nothing.
Can you speak up, Bob?
The
Sorry.
meta-analysis for primary prevention that the task force did showed nothing for aspirin. In fact,
Right.
more harm.
And I,
But
So that's why
what
we're not
we
using
did
it.
in San Diego, right, and Bob was right in there, you know, fighting the good fight on the ALL protocol, the aspirin, lipid lowering statins, and lisinopril. We really knocked down the overall cardiovascular death rate.
I'll speak.
But, so the meta-analysis for people that are, so people in primary care who are not at risk, they looked at all the studies, and particularly a big one from Japan that came in late. But the conclusion was that either no benefit or more harm than benefit
Right.
for, in primary.
So,
But if you studied the people with LPA, you find benefit. So, you know,
so that's a major
we just have to,
change.
we have to learn to screen people better genomically and biochemically, because we have patients who have a big risk for inability to efflux cholesterol from the cell. Nobody was able to measure that before you came. There's no way that you would know that, but with pre-beta-1 HDL you will, and I think eventually cardiologists will be ascertaining who has impaired efflux because they require more intensive treatment.
yeah, my final point on this, and this is great discussion, is that, all right, if this is so helpful, then when do we do it? So are we talking about a 5-year-old? If it's high, you put them on lifelong aspirin since age 5? What are the outcomes for that? And I think
We
those
have to have
are
studies to tell
areas.
us.
Well, that's
We're
kinda
just
where we
opening,
need to know,
we're
so we
opening
know
the
better.
question.
Yeah.
But I will say,
For me, like practically, I see patients for possible TIA or stroke. I say, oh, you know, you have a lot of risk factors, but I don't think it's this. And they're not on aspirin for primary prevention anymore. That's a patient where I would maybe test lipoprotein(a),
Yeah.
an adult, but I don't know if that's, I mean, that's currently not standard of care.
and I would re-mention the children with stroke that we're seeing.
Yes, absolutely.
14,
We check it.
high LPA,
We check
you know, there's a reason for doing it. I want to say a little bit about HDL, because most doctors still think of it as something. There are at least 25 molecular species of HDL in plasma. We found the one that killed the trypanosomes, for instance. So, you know, what else goes on there? There are some that are antioxidant. There's some that, you know, they have other activities. And so, you know, we consider one of our leading tasks to push this ahead. And, but just to show you how, I'll tell you something we haven't published yet, but we found a mutation that causes low HDL was associated with ovarian cancer. We found another mutation that causes low HDL that's already been reported with ovarian cancer. We have now found about 12 HDL species in the ovary. And we're going to isolate them, characterize them, but I think that they're there for a lot of purposes, but I could imagine they're there to protect that ovum. That's going to be a person, that's the most important cell in that woman's body. And we know that they're antioxidant, antimicrobial, and so on. And I think that there may be something there that prevents cancer as well. So that's why we're working very hard on HDL in various tissues. I think the bottom line is, with 25 molecular species of HDL in plasma, we know about 7 of them at this point. And pre-beta-1 HDL is enormously important because it tells us about efflux. So, you know, let's keep tuned, but there even some of the proteins in HDL can be measured by ELISA, and one of them I would suggest is ApoM, because it's got, I guess I've read and I can't tell you, some extremely important metabolic function that will be emerging. So we could be running ApoM levels, some people, you know, it's not out of the question. Okay, I just want to indicate where things are going and say a little bit about reverse cholesterol transport, because it's keeping all of us alive, okay? So, if you're interested in that. So, here's a cell that would like to get rid of cholesterol. It's in an artery wall, and there's too much of it there. So there are some genes that have been identified by some Norwegian colleagues of ours they kick the free cholesterol out. And that particle that we discovered, pre-beta 1, is what accepts it. And then it's acted upon